Thank you very much for the privilege of this presentation. Today, I will be speaking to you about a project using decision and cost-effectiveness analysis to define a hypothetical risk threshold for venous thromboembolism, which should trigger prophylaxis among pediatric trauma patients. First, we'll start with a bit of background and challenges. It's difficult to precisely estimate the risk of VTE among pediatric trauma patients. Similarly, it's difficult to estimate the long-term consequences and costs of this phenomenon. There's unclear efficacy of chemical prophylaxis in children compared to adults. And finally, those who are at highest risk for VTE are often at a prohibitively high bleeding risk related to VTE prophylaxis. All of these challenges contribute to a lack of clarity behind the question of which pediatric trauma patients should receive VTE prophylaxis. EAST guidelines make conditional recommendations for when to give and withhold VTE prophylaxis for pediatric trauma patients. However, they stress that there's a paucity of published data and very low quality of the available evidence, which helped to inspire my interest on this topic. I aimed to use decision and cost-effectiveness analysis to arrive at an appropriate hypothetical risk threshold above which VTE prophylaxis should be considered for pediatric trauma patients. For those not familiar, decision and cost-effectiveness analyses are methods which estimate the effects and/or costs of a choice. They take into account both the likelihood and value of the consequences of a choice, suggesting a choice which will maximize the studied outcome. Our methods included constructing a model of VTE prophylaxis in a program called Triage Pro, which incorporated 3 events: VTE, bleeding, and post-thrombotic syndrome. We determined the probabilities of these events and then the utilities of the various outcome states. We also incorporated the costs of each outcome, and then we ran sensitivity analyses. Our model is as follows. It asks the hypothetical question, should we give VTE prophylaxis? If the answer is yes, the hypothetical patient could experience a bleed related to prophylaxis. The patient could then go on to develop VTE or not, and those with VTE can develop post-thrombotic syndrome or not. If we don't give VTE prophylaxis, we mitigate the risk of bleeding, but those patients are then subject to the risk of VTE, and those with VTE are subject to, again, developing post-thrombotic syndrome. Each of these outcome states has a utility, which is proportional to the other outcome states, as well as a cost associated with it. And furthermore, each event has a probability of occurring. Let's take a step back and consider a hypothetical patient. Let's take a male, 13 years old, who's out riding his bike, hit by a car, ends up at a major trauma center, undergoes surgery, and is intubated in the ICU. Using previously published risk prediction tools, we can arrive at his predicted probability of VTE. He is age 13, intubated in the ICU. Let's say he receives a central line at some point and undergoes major surgery. He has a calculated risk of around 2.5%. Now let's flip back to our hypothetical model. In the middle column here, we see the base case values that I used and derived from literature review. And then on the right, we see the distributions across which each variable is varied under the sensitivity analyses. I'll draw your attention to this first line, the probability of VTE off of prophylaxis. We used our hypothetical patient to inspire this base case value of around 2.5%. But again, we see that this parameter is varied over a distribution from 0 to 5%. First, we'll start with a simple decision analysis, which just takes into account the outcome of utility. Using our model, VTE prophylaxis was favored using the base case values. This is a one-way sensitivity analysis, which reveals an inflection point of 0.57%, above which giving VTE prophylaxis maximizes utility. If we change this to a cost-effectiveness analysis, which again takes into account both cost and utility, again assuming base case values including a probability of VTE of 2.5%, giving VTE prophylaxis both maximizes utility and is less expensive. And in the cost-effectiveness analysis world, we term this cost saving. When we run a one-way sensitivity analysis on the probability of VTE, we arrive at two more inflection points. 1.8%, above which giving VTE prophylaxis is cost-saving, again, more effective and less expensive. Between 1 to 1.8%, this is termed cost-effective at a willingness to pay threshold of $100,000. And below 1%, giving VTE prophylaxis is neither cost-saving nor effective. Finally, this analysis is termed a probabilistic sensitivity analysis, which is really the strength of the model in the program. It's able to vary all parameters simultaneously. So assuming a probability of VT of 2.5%, but again, varied over a distribution of 0 to 5%, as well as varying all the other model parameters, the choice to give prophylaxis is cost-effective or cost-saving 70% of the time, as represented by this line in red. So in conclusion, assuming a probability of VTE of 2.5%, giving prophylaxis is less expensive and more effective. In other words, it's cost-saving. The threshold at which giving prophylaxis is cost-saving is greater than 1.8%, and the threshold at which giving prophylaxis is cost-effective is greater than 1%. On sensitivity analysis, incorporating the various distributions, giving prophylaxis is cost-saving or effective roughly 70% of the time. Our model has significant limitations, including that it makes major assumptions, including no risk of death related to VTE, though this does bias our model towards higher thresholds. It generalizes some highly variable situations, including major versus minor bleeds. And again, I can't stress enough that the true probability of VTE is unknown and likely highly variable between patients. However, we can feel confident about these broad conclusions. For moderate to high risk patients with low bleeding risk, prophylaxis maximizes utility and is likely cost-saving or effective. I'd like to thank the following individuals and thank you all for taking the time to listen to this presentation.